Hello, and welcome to another podcast. Today, we're going to talk about the management of asthma. Asthma is something that is excessively common. You'll see it both in the primary healthcare space and in the emergency space. It's both a disease and a series of symptoms, and a lot of research goes into asthma, especially the chronic disease, in how to ensure that people's symptoms are better under control in order to live a more fulfilled life and not essentially exacerbate asthma into one of the chronic conditions like COPD. Today, we're going to focus on the emergency aspect of asthma, and there's a little bit of research that has happened in that with changes in protocols over the last couple of years. So we're just going to go through asthma, talk about what it is, what can trigger it, and then the management of it in some details. So we'll start with the usual introduction, and we'll just have a little bit of an overview of what asthma is and why it can be quite confusing for people, especially as they're starting their clinical career, to get their head around. So asthma is a diagnosis, and it's often a diagnosis given as a chronic disease. So people will often inform you that they are in fact asthmatic. And that generally means that they have a common trigger which exacerbates the asthma-like symptoms. And most of the time, these people are on some sort of an asthma plan, and they have means of escalation. So that's the chronic disease, and that's where your asthma council will do a lot of its research, and people will be on a series of medications. But to make it more difficult, we have the chronic disease, and then anybody at all exposed to the right triggers can have an acute asthmatic attack. So you don't actually have to be asthmatic in order to get an asthmatic attack. And as we go through the symptoms, we will discuss a lot more about things that can trigger it. And at the end of the day, if it looks like asthma, then you treat it like asthma, regardless of whether or not they've had an asthma symptom in the past. There's also significant overlap in the primary healthcare space and the emergency space. A lot of times people will present to primary healthcare and they've had asthma-like symptoms develop over a series of days or even weeks sometimes, so their body's really good at compensating for it. And it's not until you move into the realms of auscultation and peak flow or spirometry that you do pre and post with a beta-2 agonist that you'll actually find out that the person has asthma. And that's really most of the time the way you will find asthma type symptoms in the primary healthcare space. But you can also get called to a scene of someone that's having an acute attack, and it can be a life-threatening emergency that must be dealt with quite aggressively in order to manage them and bring them back from that emergency threshold. From there, they'll generally go on to long-term management, but sometimes after an acute asthma attack, that can be it. They can just be done. As far as prevalence go, asthma is often associated with children. Now, the simple reason for that is children have a smaller airway. So any form of inflammation or irritation to a child's airway is going to result in asthma. And a lot of the time, the diagnostic criteria used across the globe for children is if they have difficulty breathing that responds to a beta agonist, they get diagnosed with asthma. And that's it. So hence why the numbers are so profound. To the extent that over 50% of people that had been diagnosed with asthma as a child no longer suffer from asthma by the time they reach early adulthood. So you'll meet a lot of people that will say they had asthma as a child, but it hasn't been a problem for them for many, many years. As far as the way epidemiology changes across the ages, when they're little, it starts with males getting more problems associated with asthma. Now, believe it or not many people know that when you're dealing with young people, a male's airway is actually smaller than a female's airway at a young age. Now, obviously, that changes post-puberty into adulthood, but at a young age, it's the male's airway that is actually smaller than the female's. When you get to around puberty, it's pretty equal between males and females, same number of cases. Once you get over the age of 40, it's actually quite rare to have men who suffer from asthma after the age of 40. Now that's asthma, doesn't mean they can't get emphysema or COPD, but you'll find that females are more likely to suffer from asthma over the age of 40. Because we've talked about the complexity and the range from the acute to the chronic, from the PHCT to the emergency, there's been a few ways of defining asthma over the years, but the way that most pieces of literature define it is in 4 stages, and the PCCM quantifies 3 of the stages in its treatment protocols. The first one is the intermittent stage, and that's really the early stages that you'll see walking into PHCT, primary healthcare presentation, and they'll have a reduction in peak flow. Not a huge one, but there'll be a marked reduction that responds well to beta-2 agonists, and that's intermittent. Then you'll have mild and moderate, severe, and life-threatening. Now, each one of these stages have quantified symptoms that we'll talk about, and they have different levels of aggressiveness as regards to treatment and pharmacological interventions. So today we're going to focus on mild, moderate, severe, life-threatening as the 3 categories of management, and we'll discuss what needs to happen for each one of those. But before we get there, let's talk about the way people get asthma and what causes asthma attacks to occur. Now, it's pretty much broken into 3 main categories. We have our inflammatory, and inflammatory is also linked to that allergic sort of response. You don't get an allergic response without some sort of inflammatory response. So allergens is the leading cause of asthmatic attacks. Okay, but then you also have irritants, which can be quite difficult to define because irritants will often overlap with others when you're dealing with pollutants or something that irritates the airway, causing that irritation. So factory workers, people that work with harsh chemicals can often get a respiratory inflammation. And then of course you can get inflammation from pathogens. So people may in fact have some sort of respiratory infection, but they present with asthma symptoms, and you treat their acute asthma symptoms the same way you would any other asthma attack. Moving away from the inflammatory process, you can get irritants, and this can be quite confusing because the irritants can be people exercising, exposure to changes in temperature, often cold, and it can even come from a psychological or stressful means. And this is where your muscarinic receptors come in to play as opposed to your inflammatory processes. So when we talk about pathophysiology, there's a number of different pathways that can cause the airway to close over. You obviously have the inflammation, and you can also have the bronchoconstriction that's caused from the muscarinic receptors. So remembering your muscarinic receptors is an aspect of the parasympathetic nervous system, and among doing things like peristalsis, it also causes our bronchoconstriction and obviously several other parasympathetic responses. So that's where the link comes into with the irritants. You can get a bronchospasm, if you will, or some sort of bronchoconstriction as a result to an irritant on those muscarinic receptors themselves. And then from there, there's obviously a bunch of other things that are just a little bit ill-defined, like medications like aspirin and tobacco smoke or breathing in any sort of smoke like pollutants can also cause it. It often gets confused with irritants and inflammatory, but in reality, it doesn't actually cause either one of those, but it still causes some sort of airway collapse. It causes some sort of bronchoconstriction. Gastric reflux is another one that is often overlooked, but will often present in the primary healthcare space as opposed to an acute attack. And that leads us to the complexities of the pathophysiology. Most of the time, when you read literature or you read textbooks or you try to get an understanding of what's happening with asthma in regards to pathophysiology, you will often learn about the chronic obstructive disease that is asthma. And that is where you will actually get manifestations of the smooth muscles. They'll go through hyperplasia. You'll actually get enlarging of the mucoid glands, so you're more susceptible to producing a large amount of mucus. And any trigger of inflammation within the lungs will often come with a more exacerbated response, and it generally means that the trigger is easier because it's in adulthood. It's like you resorted back to having a child's airway. It's reduced in size around the bronchioles in particular, where the mucus glands sit. And in childhood, we didn't have much to do with anyway. So you already have a smaller airway, which doesn't take much to sort of close over. So when we talk about it in an acute sense, we talk about the different triggers. Obviously, the different triggers are going to result in some sort of difference to do with the pathophysiology. When we're dealing with the inflammatory process, we will get inflammation of the basement membrane. That basement membrane will temporarily thicken in the acute stage. Now, this will stimulate the production of mucus from the mucoid cells found in the bronchus and the bronchioles, and they will produce a mucus plug. And this mucus plug is generally where you'll hear a lot of that wheezing, but it's also where you'll get that air trapping effect that you'll find with asthma. So a lot of times with the pressure coming in as a resulting of inspiration and the negative space being created, people can generally get air in the first time. But then when the contraction occurs, and the contraction of the diaphragm and the relaxation of the actual intercostals occur, then the air gets trapped. It gets trapped because it's creating an increased pressure at the bottom, sort of creating a balloon, and the small bronchioles that have mucus in it will actually stick together and it'll create a plug, and that way the air will physically have to be forced out. So it can be quite exhausting for the asthmatic to get the air out, which is why they will often have a tripod stance in order to push this air out. And you'll also find clinical features associated with how bad the asthma is associated with how much air is getting out in between each breath. Now, in the absence of inflammation, if you have an irritant trigger or something like that, then what occurs is the airway, the bronchioles themselves, will actually just reduce in size initially. And then it's only through the increased irritation of air movement and pressure that will cause the production of the mucus. But either way, you're going to have a reduction in airway size, which will give you that characteristic wheeze. The magnitude of how difficult it is to get air out will often be the defining feature between whether it is mild, moderate, severe, or life-threatening. Obviously, in the life-threatening space, we're dealing with chronic closure of the airway to the point that the air can actually be silent. So linking what we can sort of understand about pathophysiology, trying not to get confused with the physical manifestation of the chronic disorder, we'll have a look at the clinical features and we'll give you some clues of what to look for when we're dealing with an asthmatic attack. So typically they're divided mild, moderate, then severe, then life-threatening. Now when you're dealing with mild, moderate asthma, you actually need all of these as opposed to any of the others when you're dealing with the other criteria. So mild, moderate asthma, people can walk. Okay, they can speak in sentences and will take a breath. They'll tell you that they'll have shortness of breath. There'll be some sign that there's bronchial restriction, and there's often a problem with their SpO2. SpO2s are generally below 94, okay, but it's not too bad. Okay, this is the borderline between someone walking in to clinic not knowing there's a problem to people just sort of getting an understanding that it's difficult to breathe. You'll often find people will come in with mild, moderate asthma after climbing a hill or walking upstairs. They will be out of breath, they'll find it difficult to catch their breath thereafter, and they'll feel like there's some sort of restriction there. But as you could imagine, it's not too bad. If you have an asthma to choose, this is the one that you want. Once the defining feature between mild and moderate when we move into severe is associated with how hard it is to get that air moving in the body. So all the symptoms are associated with air movement. So the inability to speak in sentences means the dysregulation of breathing patterns. The only way you're hearing voice now as I'm talking to you is because air from my lungs are passing out of my lungs over my vocal cords to create a sentence and words. If I cannot get enough air out and I cannot regulate my breathing easily, then obviously I won't be able to speak a sentence fluently or comfortably, which denotes a air movement problem. With that, you will often see them visibly having problem breathing. You'll see them trying to catch their breath. Classic example of this is just watch people after a really hard PT session. Try to have a conversation with them after they've done something like that. That is what that severe level of asthma will look like. That transcends into respiratory distress, and respiratory distress often comes with the use of accessory muscles. Now, most of the time, we don't need to use accessory muscles to breathe. Now, that's our sternocleidomastoid, okay, which often cause tracheal tug when you contract that in order to get extra. Your accessory muscles and your accessory cranial nerve is getting involved. And you can also see intercostal muscles contracting instead of actually just relaxing. Intercostal muscles normally just recoil, as opposed to the internal intercostal muscles contracting to physically get that squeeze of the thoracic cavity. And you'll see that. If you've got an SpO2, which you should have because you're a clinician, then you're seeing the SpO2 being lower, around that 90 mark. And as you can see, it's really like you'll see someone mild, moderate, severe. It's just that threshold tip of, they're relatively comfortable to, or you're having trouble air moving. If they have any of those symptoms, then that is severe. If they have any of the life-threatening symptoms, then we up the ante again. So if the manifestation of severe and this difficulty moving air has gotten bad enough for them to be visibly cyanosed, they have pretty much no breath sounds at all, so the air isn't moving at all. That's a really good sign. They're collapsed and they feel physically fatigued from working their ass off trying to breathe. Okay, any of those signs, nice and obvious. It's starting to look a little bit like a medical emergency, sort of like criteria 2 of anaphylaxis, which is that bronchospasm-like effect that they're talking about. The air just isn't moving anymore. Okay, so it's life-threatening. So you treat it like life-threatening, and we follow our anaphylaxis protocols. If they don't have these symptoms, and they're pretty good, they've been able to hold on a little bit longer, and they're looking more of that severe space, but their SpO2 is less than 90%, then you treat them into that life-threatening category. Okay, and the reason they're divided this way because it will come down to the aggressiveness and the type of medication you use, and often the escalation you use if they don't improve is often determined by the severity that they're actually at. So when we move on to management, that is the first thing we do. We grade the severity based on looking at them, clinical consultation, however long it takes. As soon as you denote that it is severe or life-threatening, then conversation's over. You start treating, and you start treating pretty rapidly. Mild and moderate, you've got a little bit more time to have a conversation with them, coach them through some things, and then you can go from there. But as soon as you identify that it's a problem, then you move straight to the next step, which is, of course, giving the interventions. In the event that it is life-threatening, then you have a choice. Okay, if they can physically take nebulizer, so if they can physically move air, then you use a nebulizer of salbutamol. And if they can't move air, then you go straight to anaphylaxis. Or realistically, if they can't move air and they're looking like they're in that anaphylaxis life-threatening stage, then you immediately stop what you're doing and you use adrenaline. And that's the same thing across the board. If that ever happens to your patient at any time during the entire management, then you revert straight back to that medical emergency intervention, life-threatening intervention, same as anaphylaxis, you give the adrenaline. If they're sitting in the mild, moderate, severe space, then we start with salbutamol. And we start with salbutamol MDIs. So that's metered dose inhalers, that's the puffer, and you always use a spacer. Someone's moved into that severe space, then we couple salbutamol with ibupropion bromide. We want that beta-2 agonist effect to physically open up the airways using that andretic receptor. And then we also want the muscarinic receptor to be blocked, which pretty much allows for only one receptor to kick in. Okay, so the ibupropion bromide doesn't cause bronchodilation, but it stops the ability for bronchoconstriction to occur. Once you get to a realm of severe, then you start to entertain the idea of whether you're going to use an MDI, puffers through spaces, or whether you move into the realm of using a neb. And that is a decision that often confuses people. Okay, it's often assumed that a nebulizer is going to be better for a patient over an MDI. Now, I'll let you know now that the evidence doesn't support that notion. So if you look at salbutamol itself, an MDI puff is 100 micrograms. A salbutamol neb is 5 milligrams. So you're talking 50 puffs in strength is one nebulizer. But they both have similar effects when you're giving around 12 to that 16 mark of the actual puff through a spacer. Salbutamol, being a beta-2 agonist, works effectively on the area that it touches. So if it's able to get into the lungs without a significant amount of overflow, you actually won't have an increased amount of the other beta-2 effects like increased heart rate, that sort of thing that you often get from the nebulizer. Nebulizers themselves also come with an inherent increased risk of transmitting a viral infection. So they actually will aerosolize the droplets of any viral infection. So if this asthma is caused by a pathogen, then you can in fact aerosolize that, increasing the risk to yourself and obviously others around you. Now we'll discuss a little bit more about oxygen, which obviously comes into the place when we're dealing with nebulizers. Because a lot of the time, places recommend that you nebulize using air instead of oxygen. But if you're not carrying, or you don't have the ability for an actual nebulized machine that uses atmospheric air in order to concentrate it and increase the flow out to about 6 liters in order to create a good nebulized effect, and it's actually recommended a lot of the time that you don't use a nebulizer because you're giving oxygen at the same time. And giving oxygen to asthmatics, as crazy as it sounds, actually comes with an inherent risk associated with it. So not all asthmatics get oxygen. Okay, not all asthmatics need oxygen. Now, it's not just a matter of needing oxygen. Having increased amount of oxygen therapy can actually make patients worse when you're dealing with obstructive airway disorders like asthma. Now, the association with giving oxygen to patients with COPD has been well publicized across the board. I mean, everyone has an idea that if you're going to give people with COPD oxygen, it comes with an inherent risk of lowering their respiratory drive, therefore creating a worsening effect in what's known as the ventilation perfusion mix match. And this can result in the release of hypoxic pulmonary vasoconstrictors. And those vasoconstrictors can actually result in an increase in partial pressure CO2. So it increases the amount of CO2 found in the blood, which obviously has a flow-on effect to acidosis, which is already a problem associated with asthma. Now, this same effect that we've known for a long time to do with COPD is the same case with acute asthma, being a pulmonary obstructive disease, and also you find the same thing with pneumonia. So the recommendation is you don't start oxygen therapy unless they're less than 92%. And you give oxygen therapy until they get to that threshold of around 95. So sometimes nasal prongs are good for asthmatics, as crazy as it sounds. And if you're going with nebulizers or Hudson's or anything like that, it's often too much, and you'll go over that 95 SpO2, which is the threshold that increases the risk of this ventilation perfusion mix match, which can lead to an increase in CO2. So that can be another reason why nebulizers aren't actually the best point and call, okay? Especially when you're dealing with mild, moderate, or severe. Once they move into that life-threatening realm, they're already pretty bad, and you've got to be able to get that in, and they're generally too exhausted, too drowsy, they're under the effects of the actual disorder at too great of a level to be coherent enough to take MDIs which leaves us with just nebulizers and IM adrenaline as your point of call. So pretty much bottom line is if you have a choice and someone is able to use an MDI, a puffer with a spacer, then you use a puffer with a spacer for both salbutamol and ibuprofen bromide. Always give the salbutamol first because it's an androgenic stimulator. It's going to have the immediate effects that you want, and then you back it up with the ibuprofen bromide. Okay, you never do it the other way around. You will not get the immediate effects that you're after. Okay, so there's your recommendations, not just from me, but across the board. Okay, so always make a decision that nebulizers may not actually be the best point of call, and not all asthmatics will actually need oxygen, and giving them high therapy of oxygen can actually worsen the effects. So obviously you start with medication, and then after you've given the medication plus or minus some oxygen, you move into reassessment. Now, as far as the doses go, they also vary depending on the severity that you've ascertained. So when you're at the lower end of the problem, you're dealing with mild and moderate, you have a range of choice dealing with MDIs. You have 4 to 12 puffs. So if someone's mild, then you start with 4, and you basically keep building up until you get to a point where you feel like they've had enough. If they're on the end of the moderate, getting close to that severe, then you'll give the 12 puffs. If you're definitely confident that it's severe asthma and you're using salbutamol MDI, then it's 12 puffs. You don't dick around with anything less, you give the 12 puffs. If they're at that severe level and they're unable to take the MDI, and especially if they're in that life-threatening realm, but they're still able to move air, then you can obviously move to the nebulizer. The nebulizer is a 5 milligram nebulizer, and you give that all the puffs as a stat dose, and then you either repeat it every 20 to 30 minutes if it's mild or moderate, or you give it when it's needed if it's severe. Every 20 minutes is a rough gauge, or you give it continuously if it's life-threatening. That means as soon as the salbutamol nebulizer runs out, you pour another one in. And you just keep doing that as long as they're in that realm of life-threatening. If you've quantified the asthma as severe to life-threatening, then you can add the ibuprofen bromide. You can still use an MDI and should use an MDI if the patient's able to take it. So after you've given your 12 puffs of salbutamol, you follow up with 8 puffs of ibuprofen bromide. If you're dealing with the life-threatening or they're unable to take the MDI, then you add a 500 micrograms amount of ibuprofen bromide to the nebulizer that has the salbutamol in it. Now you give the ibuprofen bromide as a stat dose, but then you don't give it again for another 20 minutes. So you don't keep adding ibuprofen bromide regardless if you're adding a bunch of salbutamol. Salbutamol is fast acting, if it actually burns off a lot quicker. Ibuprofen bromide is slow acting, so if you end up giving triple doses within the first 20 minutes, then they're going to have worsening effects and obviously have side effects associated with ibuprofen bromide that can be anticholinergic in nature. Okay, so always just give the one dose, wait 20 minutes if they need it, then you can give another dose. You do that for the first hour, and then you pretty much stop unless you're consulted to do anything else. Okay, but once you've given that dose of MDIs or nebulizers, then you reassess after the first dose has been given. And the reassessment side looks very similar to the actual first category size. In order to denote that someone is now or remains mild or moderate, they must have all of the criteria. They are alert, they can walk, they can finish a sentence in one breath, they're not in respiratory distress, you can have a small wheeze or normal lung sounds, and a relatively normal respirate and a relatively normal SpO2. So they need all of those. If they don't fit all that criteria, then they still can be classified in the severe case. Okay, and therefore you treat them or continue to treat them as a severe. To quantify severe, you only need one of the criteria that's listed on the screen. Okay, that's it. Very similar to the use of accessory muscles. They're positioning, they're hunched forward, they're obviously having physical signs in rest rate, heart rate, or SpO2. Okay, heart rate can be a difficult one, especially if you've used nebulizers. Okay, but that puts them in the realm of severe. And life-threatening is obviously as it was. You've got that unconsciousness, exhausted, collapse, severe respiratory depression. As soon as you get absent chest movement or no movement at all, you automatically up the ante to adrenaline. And that is it. Okay. But after the reassessment, we see where they are, and then we continue our management from there. And our management continues regardless of where we are. So if you're still in intake on the ground waiting for a vehicle, you do it there. If you're in a vehicle moving towards another place, you do it there. If you're in a treatment team, if you're in a roll 2 echo, the treatment remains the same. And you continue with the medication based on the severity. You just keep giving those doses at the intervals that it is needed. So for mild and moderate, you just keep giving the 4 to 12 puffs every half an hour for the first hour. See how good they are. If they don't respond, then you start to escalate it, which we'll go on to. So if they haven't responded within an hour, then you get a bit of escalation. If you're dealing with severe, you're giving them these doses every 20 minutes or as they need it. That's what the criteria is. So if you're dealing with mild and moderate and you're not quite sure whether or not they need another puff because they're starting to look a little bit more severe, then you can also give another dose as they need it. Bottom line is, if people need salbutamol, you give them salbutamol when you're dealing with asthma. If you're in the realms of life-threatening, then it is continuous, now nebulized salbutamol. On top of that, you start corticosteroids within the first hour. Now, obviously, corticosteroids aren't going to kick in within the first hour, but you give it anyway because you want that buffering effect later on down the track to either help with their management or to keep them in that management if your interventions have worked. Now, like the MDIs, the oral prednisolone 50 milligrams is preferred over the hydrocortisone. So if they can take an oral tablet, then you give oral prednisolone. If they can't, then that's your indication that they need a cannula, and you give the 100 milligrams of hydrocortisone. From there, with the continuous treatment, you get to the hour point, and then you make the call. Okay, if they're still in the very acute stage, you don't stop treating, but you make the call whether or not they're improving or whether they're not improving. So people will either improve within the first hour or it's resolved, or you'll get to the point that it's not improving. And from there, that's where we need to make the final call of what sort of managements we're going to go on with from that point. So in the event that they're not improving or they're life-threatening, so basically if they start life-threatening or they get to the point where they're not improving, then we do pretty much the same intervention is considered. So if someone has a persistent respiratory distress or an increase in wheezing on breath or the inability to move air, obviously, then on consultation, you continue to give salbutamol every 20 minutes. Make sure you have the cannulas in if you haven't already, and then other decisions can be made like IV magnesium sulfate. IV magnesium sulfate is used as another source of bronchodilators. It stabilizes the muscles within the bronchs in order to allow for bronchodilation. So it's just a third attempt in order to get some sort of dilation. Now, sometimes asthma can be so bad that the patients will actually need intubating. They'll actually need continuous adrenaline. Some of them get put on adrenaline infusion and then they get put on a ventilator. But it's not as simple as just putting on a ventilator with normal PEEP, things like that. Sometimes you actually have to increase the PEEP in order to open the airways and maintain them open during the expired air pressure in order to allow air movement. So it actually takes a little bit of fiddling with and often some pretty advanced knowledge to get someone who's suffering from asthma on a ventilator. When they're on a ventilator, they'll often need to have medication administered as well. Okay, so you actually need ventilators that are able to do this sort of thing. And that's the escalation that can occur when you're dealing with the life-threatening, but it's also the things that are considered if asthma doesn't improve over time, regardless of how long you keep giving bronchodilators, They just maintain the same. They will also go to definitive care and spend some time in ICU, intubated, ventilated, or not, depending on the case. Now, the good news is it can go the other way. They can improve. They can even resolve. Now, if they improve to a point that it's mild or it's resolved itself, then you observe them. You keep them with you for 3 to 4 hours after they improve. Now, if they get breathing difficulties, any breathing difficulty, then they're evacuated from there. The fact that they resolved, if they get breathing difficulties again within 3 to 4 hours, then they need to be evacuated because it means there's either something in the environment, something in their body, some sort of trigger that is bringing back the acute asthmatic attack. So you've got to let them go. If you don't have to evacuate them and they stay good, then they can continue to work with restrictions and with salbutamol. So you can give them salbutamol MDIs, but you educate them to use the salbutamol MDI every 4 hours with a spacer if needed. Now, if you need to use a spacer, depending on the spacer you have, will determine how much priming you do beforehand. If you're using those little cardboard ones that we have, then you prime it with 2 puffs, then you do another puff, and you actually encourage the patient to do 4 breaths per puff. So it's not just 1 breath per puff. You actually hold it in their mouth and they do 4 breaths, and they try to hold the breath for about 5 seconds, if they can, between every puff. And that's the way you administer them. Even if you're giving up to 12, you encourage them to hold it and you encourage them to have 4 breaths between every puff to get the best result. If you do 1 puff per breath, then they're actually not getting as much of a dose as they should be, which is often why your MDIs and spacers will end up failing. Now, depending on the cause, it's best to check on them the next day. And if they've got any wheezes the next day, then they evacuate for further investigation. If they're clear the next day, then they can continue to work in the environment. Obviously, just keep offering to check on them and keep lines of communication open. But then whether or not they seek help later on can be dependent on the cause. If it's actually something that you know, like there was an irritant, a chemical in the area, sure, you can maybe say they don't need to be checked up. But if there's no inherent cause, then it's good to get a follow-up to see if there's some sort of trigger, see if they need to be on some sort of asthma plan thereafter. Okay, so that brings us to the end of asthma management. As you can tell, there is a lot to go through. But in summary, asthma can present as a primary healthcare complaint and also a medical emergency. In the event of medical emergency, sometimes oxygen is not the best point of call. You only give oxygen if their O2 saturations are less than 92%, and you only give it until it's at 95. Once they get to 95, you titrate the oxygen down and make sure the masks suit the flow of oxygen that you're administering. When you're dealing with medications, MDIs can be the best choice, and you should use MDIs with a spacer correctly unless your patient is in such a state that they cannot successfully use an MDI. Then they're known as severe, realistically, and even leading towards that life-threatening, so that is a good enough reason to move to nebulizer. The probability of getting over 95% SpO2 in that state is not very high, so it sort of removes that risk, and you can give them the nebulizers. You can do it as needed or continuously, depending on the severity. Every form of asthma that isn't a walk-in gets some sort of corticosteroid. The best one of choice is oral prednisolone, unless they can't take it. If they can't take it, that is a definite sign that the patients need cannulation, and if you're putting 1 in, you put 2, and you give them 100 milligrams of hydrocortisone. You treat them for up to an hour, and then you make the definitive call of whether or not it needs to escalate to definitive care and look at other alternative options, whilst continuing treating with salbutamol every 20 minutes or where needed, or they've improved, it's resolved, and you go down the long-term 3 to 4 hours monitoring path and then checking on them the next day. Okay, so revisit this lesson, revisit your protocol, practice your asthma protocol correctly, and in its entirety, challenge each other and try to get a good understanding of what you're going to do in some of the environments we work when dealing with an asthma attack. Because remember, you don't have to be asthmatic to have an asthma attack. But until next time, take care.